Hello and welcome to the Registry Insider. I'm Bill Seifert, CEO and Executive Director of the National Registry of EMTs, and I'd like to welcome you to this episode, which is a unique episode. We're going to switch it up a little bit this week. For Thanksgiving week, we're going to do the best of, so we will share with you our best of for the last 20 or 25 episodes, and hope you enjoy it. So happy Thanksgiving to all of you, especially those of you who have to work during Thanksgiving, and as always, stay safe.
We do pride ourselves as an organization on creating reliable, valid, and fair assessments for everybody. And we are held accountable to standards within the broader certification assessment industry that require certain levels of documentation, certain characteristics of the test to be monitored. And from that perspective, it was really important for us to be able to think through how do we assess this new model in a way that is fair to candidates, that provides the standardization that we were perhaps maybe lacking with the previous iteration of the examination. So from that perspective, what we can do now is we can think through and how do we document all these different aspects? How do we integrate clinical judgment into the new examinations in a psychometrically valid way? And how do we collect the documentation that supports that and really presents that validity argument?
The community asked us to put it all together to see if a clinician could actually run a call and not just build or do an IV and push a drug and intubate and all that stuff in isolation. They wanted to see could they put it all together. So I think the IOH helped us move into this ALS redesign where we could include things like the existing domains, clinical judgment, leadership, and communication, because we all knew that we were doing that. We just weren't measuring that very effectively with the IOH.
Paul and I were talking even earlier today that I went to him and I said, now, find holes in these and break it apart if you can.
When I was first employed here, they asked me to break it. And I did. I tried to break it and I couldn't. And it just made too much sense.
A common fear that I hear or question I ask is, what are you going to do if the pass rates drop? Or what are you going to do if they plummet? And my standard answer is we've been pre-testing these items. We know how they're performing. Mm-hmm. And we know what other professions have done, the nursing board and other allied health professions as well. Yeah. They didn't see any precipitous drops when they launched this. So do we anticipate any drop on our exams? I presume not, right? From your perspective, what's the secret sauce to being able to get your kids to pass this exam?
There is no secret sauce. I think that it is a number of things that you have to have in place so that you can try and assure that your students have the best chance of success. And I always say that learning is a planned experience. So you can't just wing it. You really have to have a detailed plan to try and get your students to success.
I think you have to plan to the best of your ability, but crises will always come up. And so you have to be prepared for that. I think knowing and being up to date with the curriculum and what the testing process is for the registry. If you're not keeping up with the changes, no matter how well you educate and teach, you're going to have problems, right?
I think the answer is everything. I'll tap on to what's already been said here, but I think your instruction and your curriculum has to be intentional. Your instructors have to be knowledgeable, and everything has to be organized to actually have success in the classroom.
I think if it's possible in your school, you should be pre-testing the candidates that apply to come into your program. And you should be setting clear expectations for what's going to be involved with your program, because you want to make sure that people have the requisite knowledge and skills to have a chance to be successful in your program.
Sometimes you are in an open access institution and you don't have that ability to do that. So I think in that environment, you are put in a situation where you have to hold people accountable and you have to remediate or you need to remove. I think you have an obligation to do that to your communities of interest rather than just passing everybody through and letting the National Registry sort it out.
What are evidence-based guidelines and what role are they playing as a profession in EMS?
So to begin with, evidence-based guidelines are things that you should do to provide the best care possible for your patient. It leads to better outcomes either in mortality or morbidity so that these people have a better recovery after whatever the incident is. And the role that they're playing, obviously, is they're widely adopted by all medical specialties, whether it's nursing, whether it's physicians. And unfortunately, EMS is a little bit slower to the game. And fortunately, though, there is the group, the Pre-Hospital Guideline Consortium, that is helping to bring this to the forefront of what EMS needs to focus on to provide better patient care. So the Pre-Hospital Guidelines Consortium is a group of organizations that have a stake in this, whether it is the physicians, whether it is the employers, whether it is the providers themselves. And what they do is they get together and they look at all the guidelines that are out there, and they go through and they grade them, because like everything that's in print, not everything is of the same quality. So they try to find the ones that are most important and have the highest quality behind them so that they have the largest impact. And based off of that, they developed the reading list and the systematic reviews, and they publish that on their website.
What are the biggest issues top 2 or 3 issues facing state offices or regulators today?
Well, I mean, I think it's workforce is the biggest issue. You see, it's the hot topic of the day. And when you say, I've been around a while, seeing some things over the years, we've seen workforce come and go. We've seen hills and valleys on the workforce, and we see people create recruitment programs. We're going to start doing things in high school. We're going to start doing these and just repeat the same thing over and over. And then the workforce kind of plays off. And it's kind of like you're treating the symptom of a disease and not treating the disease itself.
If you map out the total number of EMS licensed people in our states, that number has stayed the same. We can't really say that it has decreased. However, when you look at the need for additional calls, the different roles people are taking, we're trying to do it with the same core numbers of people, yet we haven't really grown those numbers. But it may not all be a shortage in terms of we don't exactly have enough people. It may be a distribution problem as well.
I think we got to start looking at EMS differently. I truly think that the EMS we see today and the EMS we're going to see in 4 or 5 years is going to be a lot different. There's going to be more of a focus on the paramedicine models, mobile integrated health.
I think funding's at the source of all of it. When I get asked, they're like, if you want to fix EMS in one way, I say funding, because I feel like that impacts training, that impacts the workforce, as you said, that impacts organization, that impacts what we can do.
So the continued competency agenda for the future, it's to add to the other documents that are already out there, with the EMS Agenda 2050, the research agenda, etc. And the one thing that we found when we've looked through all of these other documents is continued competency was kind of mentioned, but it was never fully explored, for a better description of it. We have these various different perspectives, and the perspective of the medical director is going to be very different than the perspective of, let's say, the employer. The medical director focuses on clinical tasks or skills or knowledge, whereas an employer, yes, they want that, but they also have to worry about things such as professionalism, empathy, how you operate a vehicle, making sure that you operate it safely, how you move patients and making sure that you move them safely, how we make sure that we retain the workforce, because as we know right now, we have a challenge with that. And these are all skills that are outside of, the realm of the medical director specifically.
Simulation for sure needs to be expanded upon, and thinking about like the time segments too, thinking about maybe having micro lessons or micro sessions where people can take small bits of information and fit it into their workday and be given credit for it, and be given credit for some of the things that they are already doing on the job.
We have an idea now about who is part of our population, right? So we have firefighters, we have EMS clinicians, we do mobile integrated health, all these different things, right? So we have an idea of the demography. What what we probably need a better idea of is what are the true risk factors we're faced with. And that is a lot harder to describe. We know there's violence. We know there's mental health challenges. We know that we get exposures. But to what extent do each of these things have? And what's like the cumulative effect? Like, what happens to me in my career when I start at the beginning of my career? It was an amazing moment for me to see everyone come together because of one thing, that we all care and we have passion in making sure our colleagues, both fire and EMS, are safe and healthy and they have futures with their families. That's what it comes down to. Mm-hmm. And that's what the whole spirit of the study is. And we're at the beginnings of making this happen. And that's what is so thrilling for me.
Where's the funding coming from this? And obviously a study of this magnitude is in the multiple millions of dollars, and also will take a lot of years to have a better appreciation for, correct?
Yeah. So this is the beginnings, right? So when we first started getting this together, we started talking to a lot of our stakeholders, and the state of Florida became really interested in the possibilities because of what the challenges they're having with their workforce. And so that's how that funding mechanism worked. And so that's the first phase. Now, the second phase is going to be looking for bridge funding as we get ready to submit for NIH grants.
We became cognizant about 6 years or so ago that our operating systems that we use inside the registry to manage data, computers, that sort of thing were very outdated and needed to be modernized so that they made the workflow much more effective, made it easier for registrants and for staff and for states to handle the data and the whole process that the National Registry uses for testing and certification. And so that's been a major, major focus, and a whole lot of money went into developing that, adding staff in the IT department and revising the infrastructure that we're using to do that. And there's been some other things that go hand in hand with that. I think one of the major things that we've done is listen to our accrediting organization, the NCCA, who questioned for us what the actual utility of the psychomotor exam is. And so we took a very close look at that and said, it's very difficult to get good inter-rater reliability. Somebody takes an exam in Los Angeles. Would they get the exact same score on a psychomotor exam if they took it in New York?
That is the piece that was missing previously when we thought about competency. Everybody thought clinical. But you have the affective domain that requires competency. You have, vehicle operations that requires competency. And so we started looking at it from a broader viewpoint than just the viewpoint of the clinician.
So you're saying that competency is more than just hours?
Yes, it is more than just hours. And we're trying to leverage technology to make it a more meaningful experience for the certificate, so that just like what we are doing with the entry-level testing, making it more real-life, real scenario-based, we're trying to make it more applicable to the day-to-day job that a clinician might do.
They need to first of all, look at the practice analysis and see how it's changed, because the domains are slightly different than what they have been. And inside those domains, you're going to see job tasks. And so when you look at how those job tasks are allotted, that is really telling you what you need to be teaching in the classroom. And so, for instance, I believe there's 26 job tasks in this practice analysis, and 11 of those are in patient assessment categories. Mm-hmm. So the examination is going to reflect that. And so patient assessment will be a category that the educator for sure wants to be teaching. When you talk about clinical judgment, when you think about scenario testing, and that will remain at the AEMT and paramedic level, not at the EMR or the EMT level anytime soon. So although we may test those concepts of clinical judgment, leadership, and communication, it's not going to be in a scenario format.
One of the things that my students hear from me on a regular basis is that you're going to be on the side of the road at 3 o'clock in the morning, and you're going to look at your patient, and nothing that you learned in class is presenting the way that you learned in class. Mm-hmm. And nothing that you do is working for your patient. You still have to take care of that patient. Now, what are you going to do?
Define the goal of what a student is. What is the end goal? It's a competent entry-level paramedic or AEMT. There's somebody that's prepared to go out and do the job at the entry level. So one of the arguments that my students say, well, I'm not a doctor, I don't diagnose. I said, well, if you're not going to make a diagnosis, you probably need to get out of my classroom, because how are you going to make a treatment decision if you can't diagnose the condition? If you pulled out that albuterol to give to that patient because you recognize bronchoconstriction secondary to their asthma, you just diagnosed them with a reactive airway disease, didn't you? And they're like, oh, yeah, I think that's right. So I think for a lot of programs across the country, this new test is really not that different than what we're already doing. And I tell my students all the time, I do not care about the National Registry exam. And they look at you like, well, I don't. If I do my job, you're going to pass that exam. I don't have to worry about the exam. The exam is just a step to validate everything you went through in my program. So yeah, people get all worked up over the exam like it's some kind of major milestone. And it really is, it's a baseline, right? It's just all it is validate that, okay, you've got your education, you're ready to go.
And that they can function at a safe, effective, entry-level competent
And
level.
this is where people get really bent sometimes, right? Is when you tell them the National Registry is entry-level assessment.
Is it?
We're assessing the baseline entry-level, what it takes to enter the profession. We're not testing a 50-year medic who's doing critical care transfers and does all kinds of things with different things.
In many situations with this, quote, new exam, it's not really new for us as educators, because the content that the exam covers is the same content that we've been teaching for a number of years since we worked on the educational guidelines. I think one of the big challenges that we see right now is all the other material, as important as it is, that's coming in from different directions, coming in from our state offices of EMS, coming in from accreditation, coming in from our college or university administration. And so I think one of the things that we have to do as far as addressing that is making sure that we are vocal in a respectful manner to each one of those entities and say, wait a minute, part of the problem here is that I'm being overloaded. And nobody's being malicious about that. The problem is each one of those entities don't talk to the other. So it's much like we talk about polypharmacy with patients. Right. When you've got 3 doctors and you're getting prescription coming in from multiple different areas. What we have to do is I think we have to advocate for ourselves to each one of those of saying, is this, number one, is it really going to benefit the student in making them a good paramedic?
To that, I think one of the biggest challenges we're going to see in EMS is not necessarily the shortage, right? Everyone talks about an EMS shortage. There's a shortage of this, there's a shortage. I would argue there is not a shortage. I would argue we have allocation issues. I would argue that our students are going to places we never dreamt they would go before.
Oh, yeah.
Not everyone's coming in wanting to be a firefighter, paramedic. Not everyone's wanting to go work on an ambulance. I got folks going to the hospitals. But we're going to have a significant educator shortage. There's a lot of colleges that only put out 12 to 14 paramedics a year. And I would argue that sometimes it's the smaller programs have to work even harder to advocate for themselves.
Because they don't have the resources.
They don't get the resources because the administration looks at them and says, well, there's only 12 students a year, right? And well, wait a minute, what does it take to get those 12 students where I need to get them, right? And I need that resources. I need those helps to be able to make sure I equip my students to be successful.
Thank you for joining us for this episode. If you wouldn't mind, please click the like and subscribe buttons, as well as the notifications so you can get notifications of upcoming episodes. Also, for the latest and greatest happenings of the National Registry, feel free to go to nremt.org. Thank you very much. And again, stay safe.